But what is the latest? We know chemotherapy, right? So what's the latest? The latest is actually how we can be more specific or more targeted in our approach to treating cancer. And of course, harnessing our own immune system to go after the cancer is an even more elegant way of treating it. You remember this diagram I showed you? These are the hallmarks of cancer. It's evading growth suppression, they are avoiding immune destruction, invasion of metastases, inducing angiogenesis. For each of these characteristics, the scientists are now thinking of a strategy to counter it. So if angiogenesis, forming new blood vessels, is a problem, we inhibit the signaling that can promote the angiogenesis. If avoiding immune destruction is how the cancer survive, we find a way of activating the immune system again. If sustained proliferation of signaling or growth is the problem, we find an inhibitor to inhibit that signal, and so on and so forth. Of course, we are more successful in some and less successful in the others. Some of the drugs are very elegant, very effective, some are less so. It is still an evolving process, and I'm sure in time to come, we can see many more new discoveries into different areas. But just as a glimpse of the different categories of drugs available, on this end is the DNA synthesis inhibitor, well, simply put, like chemotherapy. They inhibit the DNA damaging agent, the degree of disease specific and precision. So how specific are these agents? How specific are these treatment on the cancer? Chemotherapy is the lowest in rank. As you move to hormone treatment, which is only used for hormone therapy or cancer that are hormone sensitive, to epigenetic modifier, to immune checkpoint inhibitors, to cell lysis mediators, these are something that's still under investigation. You become a lot more specific in your approach to tackling the cancer. And by definition, as you become more specific, you can relatively less side effects as a result. I'm going to use breast cancer and a very specific type of breast cancer as an illustration. So, in some of the breast cancer, in fact in all breast cancer, in fact in all the cells in the body, we have this receptor on the surface called the HER2 receptor. It's like an antenna. This antenna receives signal from the environment that will help the cell to grow. So if this antenna receives a signal, it will tell the cell to grow, to multiply. And if they do not receive the signal, then the cell will stop growing. In some of these breast cancer cells, instead of having 25 to 50,000 of these receptors, they have something like 2 million copies of these receptors, many fold higher. And when there's so much or so many of these receptors around, the cell will divide regardless of whether there's any signal to ask it to grow. So without somebody telling the cell to grow, it will grow because it's self-activating. If you have many of these cells around, you can imagine that this cancer that arises as a result will be multiplying, growing quicker, having a higher chance of recurrence, and a poorer prognosis. Excessive cellular division. Is this common? Well, between 15 to 20% of all breast cancers are HER2 overexpressed, or we call HER2 positive. And this is how we can test them. This is an immunohistochemistry of a section of the breast cancer. They put a dye that lights up HER2 receptors, and you can see this brown pigment surrounding the cells on the cell surface. It's a sign that a lot of these HER2 receptors are present. In fact, we recognized this subgroup of breast cancer a long time ago, even in the 1970s, 1980s. We only can tell that these cancers are aggressive. If you put HER2 positive cancer and a non-HER2 positive cancer together, the survival is half of those HER2 negative breast cancer. It was not until the 1980s that we are able to design specific drug, and in this case it's an antibody, to hit the HER2 in a very specific manner. If you give enough of this antibody, it binds to all these receptors, the cells will undergo cell death. This is an example of a patient with HER2 positive cancer. She herself is a doctor. She just delivered her third child. And during the pregnancy, she felt the breast a bit engorged. She thought it was just the usual blood engorgement. But it wasn't until she delivered the child, within about a month or so, it became pretty obvious that this blocked milk duct is actually not a blocked milk duct, but it's a tumor. They did a biopsy, it was a cancer, and it was HER2 positive. We were about to do surgery to remove the breast, but when we did the PET scan, this is the image of PET scan, the cancer is unfortunately not confined to the breast, but it's also found in the bone. This is the pelvic bone, in the liver, and in the left humerus. These black spots are where the tumor are found. So because this is such advanced disease, there's no point taking out the tumor anymore from the breast. So she went on chemotherapy and of course with the antibody against HER2. So a combination treatment, about 4 months later, there's obvious regression of the primary tumor, obvious regression of the metastasis in the lung, in the ribs, and in the liver. And this is the post-treatment scan. We call this near metabolic complete response. So we can't really detect any increased activity. Does it mean there's no more cancer? No, it doesn't mean that. It's just that the cancer has been so suppressed that you can't detect it on the scan. The treatment continued. She went on maintenance immunotherapy. The entire world is looking at immunotherapy. Why? Because it is new, it is exciting, it is working in areas that have never worked before. So every year we attend a conference in the United States, Chicago, called the American Society of Clinical Oncology Annual Meeting. And this year, 2017, there was something like 35 or 40,000 people there attending the meeting. Half the sessions this year were on immunotherapy. It's how important it is. So how does it work? Well, not all immunotherapy are the same. The one that's making the buzz is a group of drugs called the anti-PD-1 antibody. What's anti-PD-1? Look at this. So this is a cancer cell. This is our own immune cell, the lymphocytes. There's a PD-1 receptor on the cells, on the lymphocytes. When the lymphocytes are activated, because when they see the cancer cell, they see a bacteria, they get activated, they will go after the cancer cell or go after the bacteria which they see as foreign and destructive. Cancer cell, on the other hand, as a self-surviving mechanism, is able to produce this molecule called PD-L1. And PD-L1 binds to the PD-1 receptor. The PD-L1, but this is just a pictorial form, is likened to an eye shape. So when the PD-L1 that's made by the cancer is bound to the PD-1, the lymphocytes cannot see the cancer. If it cannot see the cancer, it will not go after the cancer. So what do? We design an antibody, like Herceptin. This antibody will bind to the PD-1 receptor first. Once it's bound to the PD-1 receptor, the PD-L1 from the cancer cell cannot bind anymore. So the eye can see again. In this way, the lymphocytes are reactivated to recognize the cancer cell and go after the cancer cell. Interesting. So the anti-PD-1 antibody that we give the patient does nothing to the cancer. It doesn't bind to the cancer, it doesn't kill the cancer. All it does is to prevent the PD-L1 from binding the receptors on the lymphocytes, and the lymphocytes go after the cancer. And because of that, it doesn't again have the usual traditional side effects of the chemotherapy, because it's not chemotherapy. Does it work? Well, this is an example of a patient with melanoma. Melanoma is the cancer of the pigmented cells of the skin. Melanoma has no treatment before this. Chemotherapy simply doesn't work in melanoma. If it works for a very short time, the disease will progress. But with immunotherapy, anti-PD-1 antibody, we have seen very dramatic responses. Not only just responses, chemotherapy can also cause responses like this. But it is the duration that they continue to respond. Those who responded will continue to respond the second month, third month, fourth month, 6 months, a year, 2 years, and continue to respond. And this is this is the big difference between the immunotherapy and the traditional chemotherapy. So this immunotherapy has now found its use in melanoma, in lung cancer. Compared to chemotherapy in selected lung cancer patients, immunotherapy is associated with a longer survival. This is remarkable. And in colon cancer, in bladder cancer, and the list is increasing. Not all cancer respond the same way to immunotherapy. Some better, some not at all. Same way, not all cancer has a targeted treatment. So we have to select the right patient to go for the right drug. Rather the right drug for the right patient. Like HER2 positive breast cancer only works in HER2 positive breast cancer. You give it to a non-HER2 positive, it's completely useless. So how do we identify? Because we don't have one size fit all. So selecting the right patient with the right treatment requires identifier, and the identifier is generally known as biomarkers. We need to select biomarkers so that we know where the targets are. So curing the cancer, are we there yet after all this talk? Not quite, but some of the statistics are quite encouraging. In the 1970s, this is a British data, they estimate that among 100 patients that were diagnosed, about 25 of them will survive the disease. So 1/4, 25% will survive the disease. In the year 2000, when they did the survey again, about 50% will survive the disease. Now, these are all comers, stage 0, stage 1, advanced disease. They are all comers, and they are all under various kinds of treatment. Obviously, some of the improvement came from screening, because if I can, out of 100 patients, initially in the past, we only detect 5 that are stage 1, but now I'm able to find 25 or 30 that are stage 1. As a cohort, the improvement will be, the survival will be better. So screening is one of them, but a lot of it is actually due to treatment. It's due to earlier detection, due to better treatment, due to wider use of chemotherapy that wiped out the micrometastases so that the early stage disease has a better chance of cure. Of course, the progress is not uniform. So we see overall a 25 to 50% improvement, but some cancers progresses more than the others. If you look at pancreas cancer, we hardly make any progress. We are still way down there. Every 100 patients that you diagnose, majority of them will not survive the disease. Some are not so bad. Then non-Hodgkin lymphoma, we have gone from about 25 to nearly 60%. Some are excellent, like prostate, we go from 29 to 75%, but this is a bit arbitrary because now people screen for prostate cancer, they find it earlier and earlier, they actually survive for a long time. But the real ones, like the breast cancer, went from 50% to 75%. So these are real progress. They are real progress for all the major cancers. And I think we're inching closer to the other end. So while we may not have erased cancer completely from the face of the earth, I think we are making significant progress. Just to leave you a few take-home messages. One is clearly lifestyle changes important, I think, for an individual as well as for the entire population. And early detection and treatment is always better because you can have a better outcome, better chance of cure. And now we understand the biology better, we are able to pick up what is really crucial and important for the cancer survival and design treatment that are more effective and more targeted to reduce not just the increased effectiveness but also to reduce the side effects. And as a result, we believe that cancer treatment will become increasingly personalized. We call precision medicine, personalized medicine. This is what it means. Cancer is a field, is an area that precision medicine has made a lot of headway, and we believe also in other fields, in rheumatology, in respiratory medicine. Although it's not quite as extensive, but this is the flavor of the day, so to speak. It's always an interplay between the genetic makeup of the person and the environmental factors and the tumor factors that will determine how best to treat these patients.